Hi. Welcome back. We are now moving into the last lesson, Occlusion for Dentistry course. Lesson 6, Managing Common Occlusal Problems. From the previous lessons, we have understand the stomatognathous system, the basic mandibular movement, the fundamental concept of occlusion in removable and fixed prosthodontics and implant dentistry, and learn about articulator and facebo instruments. Lesson 6 will discuss on the common occlusal problems, recognizing the problems and the management, and as part of the management, we will also touch on the topic of occlusal splint and occlusal equilibrium. By completion of this lesson, participant must be able to grab the following 4 outcomes. First, describe common occlusal problem observed clinically and their causes. Second, discuss the prevention of common occlusal problems and the management of it. Third, discuss on the different type of occlusal splints designs. Fourth, discuss when and how to perform occlusal equilibrium. This lesson 6 will be divided into 2 sections. Section 1 is managing occlusal problem, and Section 2 is about occlusal splint and occlusal equilibrium. Let's get started. There are many clinical problems associated with occlusal disorder. However, particularly in this lesson, we will only discuss 8 common occlusal problem, clinical problem and clinical manifestation derived or associated with occlusal disorder. Problem 1, repeated or failure of restorations. Problem 2, limited space to replace missing tooth due to over, erupted or drifted adjacent or opposing teeth. Problem 3, tooth wear. This problem is commonly associated with loss of space to restore the tooth surface lost due to dental-alveolar compensation. Problem 4, tooth mobility, also known as fremitus. Problem 5, direct occlusal trauma, trauma to soft tissues such as the palatal gingivae or buccal mucosa. Problem 6, splayed anterior teeth. Problem 7, abfraction, a condition with different opinion in the literature. However, the relationship of occlusal force to abfraction cavities must not be ignored. Problem 8, temporomandibular disorder associated with occlusal disorder. In the condition of tooth surface loss, or limited space due to over-erupted or drifted adjacent tooth, the clinicians may need to create space sufficient to place prostheses. There are 5 methods to create space. Method 1 is by the direct increase of the vertical dimension. The next question is, what are the factors limiting the direct increase of vertical dimension in patients? The answer will be the next slide. Method 2 to create space, reducing opposing teeth to create space. Elective endodontic treatment may also be carried out if necessary. Method 3 is by orthodontic treatment, aligning the drifted, tilted and over-erupted teeth to provide the required space. Method 4 is by implementing Dahl concept, also known as relative axial tooth movement. The last method to create space is by changing the mandibular closing position. By removing the retruded contact position on the tooth deflecting the mandible now close into the centric relation. However, this condition rarely been used to create space. To answer the question of what limits the amount of direct increase of vertical dimension, there are four factors: the facial height, the position of anterior teeth including the length, the soft tissue where the lips will play parts in phonetics and aesthetic. The last factor limiting the amount of direct increase of vertical dimension is the mandibular stability. As for dual concept or relative axial tooth movement, it is well supported by the literature from the early days. Many researchers agreed that vertical dimension, rest position, the whole occlusion is dynamic and changes occurs in time. Ramfjord in 1962 stated that masticatory muscle can adapt well to a direct increase in VD, up to 10 mm when it is accompanied by a stable occlusion. Carlson in 1979 also reported the following statement, that symptoms such as headache, soreness of teeth, muscle and joint fatigue were noted in a direct increased VD, but only last for the first few days. Changes in vertical dimension in dentate individual are well adapted and received, due to the presence of mechanoreceptor in the periodontal ligament. Occlusal problem number 8 is the temporomandibular disorder, TMD. TMD is defined as any disorder that affects or is affected by deformity, disease, misalignment, or dysfunction of the temporomandibular articulation. We will focus on category 2 of TMD, intracapsular disorder that are directly related to occlusal disharmony. As for the management, the sign and symptom can be eliminated by correcting the occlusion. Most of the time, the stabilization splint, please refer to splint section, are the option to treat TMD. We have discussed on the 8 clinical problems related to occlusion, description of the sign and clinical symptoms, and the management of this situation. A Padlet discussion forum has been provided, where students can post any inquiries or questions related to this topic. It will also be the platform for any clinical case discussion, because we might have not covered cases that you will encounter in your clinical settings. Now, let's move on to the occlusal splint and occlusal equilibrium section.